So we're going to move on to HSV. So big thing here, and we're going to be kind of quick about it, but there is obviously increased HSV risk to a neonate, especially when mom has an active lesion during delivery. Typically, if mom has an active lesion, we're going to suggest or it's recommended that a C-section be done. But it's important for y'all to know that that does not affect what we do for the infant. So I've had several cases where moms have been told by their OBGYN provider that since they're doing a C-section, that the infant will not get herpes, which is not the case at all. It is something that definitely dramatically decreases the risk of HSV to the infant, but only if they're still intact, the mom is still intact. And then also, it does not change how we treat the infant once they are born, regardless. Any active lesion, whether they're born via C-section or vaginal delivery, gets the same care, period. So we know that primary infection has about a 50% transmission risk, but this is the area where a lot of OBGYNs don't realize that a first infection of non-primary HSV has a 25% risk to the infant. What that means is if mom has a history of HSV2 infection, but gets HSV1 infection for the first time in the vaginal area, that's a first infection of non-primary HSV. And the antibodies that our body makes for HSV2 do not protect from HSV1. They are individual serology, or they're individual serotypes of HSV, and they have different antibodies, so they do not cross cover each other. And then reactivation of HSV has the least amount of transmission risk to the infant, but that's still about 5%. The majority of cases of neonatal HSV in infants, moms have no history of HSV that they know of. Doesn't mean, obviously, that they didn't get HSV. Obviously, they did. They just didn't realize that they had it. Okay, going back to this first episode, non-primary infection, the way that we tease this out is that we have to always get PCR testing of an HSV lesion in a pregnant woman who has an active lesion at delivery. That is super important. And then also getting serology for HSV1 and HSV2 on the mom to be able to determine what her status is. That's super important, and we'll kind of look at that here in a couple of slides on how that affects what we do for the infant. There is some difference between ACOG and AAP guidelines on this. I think ACOG usually doesn't recommend retesting in the pregnant woman with a history lab confirmed genital HSV, okay? But the difference is here is that they're not taking into account the fact that mom can have a first occurrence of a non-primary HSV infection, what I just kind of talked about. So the AAP asks for OBGYNs to swab all women with a lesion at time of delivery so we can assure that either that is the same type of HSV that the mom has a history of, or is this the different serotype? Obviously, mom can have HSV1 or HSV2 lesions in the vaginal area. So just like congenital syphilis with HSV in the infant, I should say HSV in the infant where mom has an active lesion during delivery, you can see that this is a huge algorithm, again, that we have to look at. And what determines where we go in our algorithm is this maternal history of genital HSV preceding pregnancy. So knowing what if mom has a history, that's so important to document in the notes again. And then also having serologies if possible, and also the PCR testing results. That's super important for us because if mom has no history, that's an automatic, that kid gets a lumbar puncture, period. If mom does have a history, we hold off on the lumbar puncture depending upon what the results are on the lesion that we get, that mom has actually, the swabs, what the results of the swabs are of the lesion of mom's lesion during delivery. Sorry, that's a lot of words, but trying to keep them separate from each other. So this is just a little bit closer so you can see it. But again, it's all based upon what mom's maternal history are. And again, you can see here it's vaginal or C-section delivery. So that C-section delivery is helpful to the infant, but it does not change what we do to the patient. So what do we see as neonatal complications for HSV? So the most common type of HSV disease that we see in a neonate is what we call SEM disease, which is skin, eyes, and mucous membranes. That's 40% of neonatal HSV, but obviously we can get disseminated HSV and localized CNS disease where there is no SEM disease as well. And this is what you're scared of, right? So CNS disease with HSV can be completely neurologically devastating to an infant. What do we have to do? What are we asking you to do as OBGYNs? Is to swab all moms with active lesions for PCR. You don't have to do the culture. I really don't care about the culture. AAP recommends that. I don't care about it. I just need the PCR, and I definitely need mom's serology. So basically IgGs for both HSV1 and HSV2. And those should be done at time of the lesion, the delivery. Okay, now I'm done. Any questions?